Good evening. This is Cindy Zolnerick, the CEO for the Texas Nurses Association. I want to welcome all of you tonight to our town hall on COVID-19. I'm sure all of us have been putting a lot of effort and energy and attention to this pandemic, and it's affecting everyone actually across the world in different ways. And so we are very interested in hearing from you and in the challenges you face and understanding how we can help. We know we've heard from nurses, lots of concerns and questions. We've heard from leaders, lots of concerns and questions. And we'll be talking about some of what we're hearing and what we know, and we will have opportunity for you to offer questions. I do want to make sure that we focus our conversation and our on solutions and moving forward. Certainly, we are not prepared for what we are experiencing. When we experienced 9/11, we were not prepared. We've experienced other healthcare challenges for which we have not been prepared. And historically, what I have seen nurses and communities do is rally together and figure out how we can best address the situation based on what we have now and what we're able to do now. So that's really how we want to focus our conversation is what are the concerns and what are some of the solutions? What are the things we can do now to help address some of those concerns? We have several TNA staff that are on the call. Belinda Ritchie, who is the Director of Member Services, is doing the background work and coordinating all the background efforts on this town hall. Serena Bumpus, who is the new Director of Practice for TNA. She joined us just 2.5 weeks ago, and we are thrilled she is here. And she has dived in, hit the ground running, and helping us respond during this pandemic. Also, Kanika Sebastian, and I'm sorry, Kanika, I always struggle with your name, who is our Director of Communications. She has a master's degree in public health, and so she has a particularly valuable perspective to offer as we consider the challenges of this pandemic. Like I said, we will be sharing some information with you and offering the opportunity for you to ask questions and entertain some dialogue and response. So with that, I'd like to introduce Serena Bumpus to begin and kind of kick off this town hall meeting. Dr. Bumpus?
Hi, can you hear me?
Yes, we can hear you.
Okay. Just wanted to make sure. I was having a little technical difficulty right before. So thank you guys for being here with us tonight. We know, as Cindy indicated, you have a lot of questions, and I think we have some answers for you, and we also want to partner with you to work through some of the solutions to help move forward and support you through this very challenging time. As we are, Monica and I will be going back and forth as you guys are thinking of the questions you want to ask.
Serena?
A question. Yes?
Serena, you're a little bit garbled. I don't know. It doesn't sound like our connection is as good as it was before.
Can you hear me now?
It's breaking up a little still.
Okay. Are you there? I'm so sorry. This is okay.
That's better.
Is that better?
Yes.
Yes.
Wonderful. Okay. We know as you think of your questions that you want to ask, we want you to use the question box on your screen to type your questions in. And we're really interested in learning what type of healthcare setting you work in, whether that is in the hospital, long-term care, home health. Give us some context to the question that you're asking and how we can help guide you. And just, to let you guys know, we have heard a lot from nurses over the last couple of weeks. We know that there are concerns out, and our survey that we sent out a few weeks ago really highlighted some of the concerns that you have, and some of those consistent questions were really surrounding, making sure that you have the right information at your fingertips. I think there's a lot of information that's being thrown out there. Some of it is accurate, some of it is questionable, and we want to help kind of clear some of that questions surrounding your practice as well. And under these types of conditions, what rights and protections are available to you in all settings. And we've been trying to put some of that information out for all of you via social media. To elaborate on that a little bit more, in 2009, Texas passed a rule with
Serena, you're breaking up again.
Again? Go down here.
I think if you talk just a little slower, it will help.
Okay. Can you hear me now?
Yes.
Okay. We're going to try this. We sent some information out about mandatory overtime, and in situations in disasters like this, that mandatory overtime rule is waived essentially, because we know that we need all hands on deck in these situations. What's important for you as nurses to know is that your hospitals still need to use your staffing effectiveness committees and your disaster plans that you have in place for situations like this to come up with contingency plans to try and avoid mandatory overtime as much as possible. And hopefully some of you are engaged in those conversations already with your leaders inside your facilities. In addition, we also know that the nursing safe harbor rule is also there for us to use in the event that feel things are not safe and that our license is at risk or patient safety is being put at risk. Just this last legislative session, we also passed the verbal safe harbor, where in the event that you have immediate patient care needs, you are able to call safe harbor verbally and communicate that with your supervisor to let them know, as long as then if you choose to continue and follow through with safe harbor, you still have to finish the paperwork at the end of your shift before you leave.
And all this information is on our website too. So if you need more info on the mandatory overtime or the safe harbor protections, you can just visit texasnurses.org to get that.
I also wanted to, there was a comment in the survey that talked about providing mandatory webinars by the CDC that gives recommendations on appropriate measures that can be taken during this pandemic and what nurses can do and how to manage these patients. I wanted to alert all of you to a resource. The CDC is doing that currently. They have a clinician outreach and community activity group that is it's an opportunity for them to reach the bedside clinician and the leaders within our healthcare organizations. And they provide webinars to discuss right now specifically COVID-19 and the impact it has on specific healthcare settings. So if you go to the CDC website and search for the clinician outreach and community activity group, you will see that they've had webinars on how to manage this in the ambulatory setting, in the long-term care setting, as well as the hospital setting. And those are all recorded, so you can go back and look at those again. And while I'm going to turn this over to Kanika now, she's got some good information from the public health side. And while Kanika is talking, if you have any questions or practice related, please feel free to use that question box, and Belinda will be going through those.
Hi everyone. So we sent out a survey to our members, and then we also put the survey online for any nurse to respond. We got maybe 300 plus comments and questions. So thank you all for conveying your questions and your needs and all of that to us. Please continue to stay in communication with us. We know that everything is changing day by day as different cases pop up across Texas. So please keep letting us know what's happening in your town, in your area, in your practice setting, so that way we can make sure to get you the best resources possible. We are looking at implementing something like a weekly newsletter at this point. We do send the checkup out every Tuesday, and that did have some COVID-19 information in it, but I'm looking at also doing maybe a Thursday or Friday follow-up because the news is changing so rapidly. Just today, I believe there was the budget that was passed. So things are just moving along very quickly right now. So we'll try to get you the latest information as soon as we have it. But we'll also try not to bombard your email inboxes. From the survey, we saw that a lot of nurses were a little bit concerned, confused about why we were taking such drastic measures so quickly. One thing to understand is there's a little bit of mass panic, mass hysteria happening, especially with the grocery store shortages that everybody is seeing. And it's easy to look at that and look at what the news is covering and think, well, this is overblown. Part of that is true. Our supply chains are not really going to falter. We will still have grocery stores open, even if this does get bad. If schools continue to be closed and businesses are closed, grocery stores will still be open as far as, every indication that we have right now. And same thing for water supplies, electricity, those types of things. So that's not really a major concern right now. The major concern is overburdening the healthcare system. And I'm sure most of you have seen this idea of flattening the curve. So, if we have a bunch of cases immediately and they spike up, then that's going to overburden the healthcare system. But if we can just let them kind of gradually set in, we can keep them below the line of what all the nurses and healthcare workers can handle. So that is the message that everyone is trying to get out right now. There was a study that the UK did, which I believe was published today or very late last night, that did a lot of modeling. So they were looking at what is this going to look like if we take certain measures? What does it look like 6 months from now, 12 months, 18 months, 2 years? And their determination was if we continue in this sort of self-isolation and social distancing that we are implementing currently, that probably in about 18 months is when we'll have a handle on it. Now that is just preliminary, it's just come out, and we will link that for you. After the webinars, we'll have like an FAQ that we put up, so we'll link that for you. But I just wanted to give you a sense of the kind of time scale we're looking at, and part of that is because we're trying to develop a vaccine. There are several candidates currently being tested, 5 that I've heard of recently. So the vaccine development is moving along very quickly when you consider kind of the laboratory side of it. What we are still waiting for is the public health side of it, making sure that there's no long-lasting effects from the test volunteers, and just making sure that the vaccine is still effective. We still don't know yet what the course of this virus will look like. We don't know if it'll be seasonal like flu. We don't know if it'll stay at high numbers even in the summertime. And we don't know if it, like flu, will mutate so much that you need to get a new vaccine every winter. We have a lot of questions that scientists are still looking for answers for. And so all of this is ongoing. Things that I say today, we might discover tomorrow are slightly different or completely different. And so everything I say today, we will put links for you on the FAQs on our website, and we will try to stay on top of those links. If you hear anything different, please do send it to us. There's so much coming out that we're missing things too. So send it to us. We'll try to stay as on top of it as possible and put everything in one place for you so you don't have to hunt around for the information that we know that your colleagues and your patients are looking for. Some of the other kind of misconceptions is this idea that we already have cures or that the flu shot is a cure for it, or that it'll prevent you from getting it. And part of that is because of when the first cases were first reported, there's a lot of mixed messages in the media. So to clarify, if any of your patients come asking about the flu shot, the reason they're encouraged to get the flu shot is to reduce that burden on the healthcare system again. So we just want people to avoid getting the flu, because then if they end up hospitalized, that's another bed that is taken away from someone that might end up with COVID-19. And then every person that has COVID-19 is taking a bed away from someone that's in a car accident or has a heart attack. So that's what we're attempting to do right now. And that's something that we're really wanting all our nurses to communicate to patients, is we're kind of all in this together. So if you're safe and other people get sick, you still might be affected if you need to go to the ER sometime down the road, but there's no beds free because everyone is in there with COVID-19. So that's something to kind of help, help your patients understand the seriousness of this and what's happening. And then some of the over-the-counter treatments, just watch out for. People have been talking about drinking bleach, or that just doing a saltwater gargle every day is going to cure it. None of these are proven. The basic way that you get the disease is hand-to-face contact. It's going to enter through one of your mucous membranes. It's mostly because of hand washing that people are getting it. They're touching surfaces. It lives for days on surfaces, depending on the material. And so that's the main way people are getting it. The other way is direct contact with droplets in the air from somebody who coughed or sneezed out infectious particles. And that is about a 6 feet distance. That's why we're saying social distancing up to 6 feet. So nurses are really going to be at risk here. So we know a lot of you are worried about PPE. Serena or maybe Cindy is going to speak to that later. But we know that nurses are in that high risk group because of how close you have to be to deliver patient care. And there's been a lot of different protocols going around about isolating patients. We had some questions about whether they should be using the droplet protocol or if you should be using the airborne protocol. Right now, every indication is that this is droplet based. It is not airborne like measles, as far as we know so far. There was a study that was popularized in the media where they talked about it surviving in the air for 3 hours. That was in the air in aerosolized form. So it was not just in the air without the droplets. So there's some things to just keep in mind as you see the news reports coming out. And some of these studies that are coming out so quickly have not been peer reviewed. And so just watch out for that little disclaimer when you go to like the Lancet or another medical journal. Yes, it's a reputable journal. The scientists are probably reputable researchers, but some of them haven't been replicated and some of them haven't been peer reviewed. So just keep an eye out for that and just take it in the context that it's given, and don't kind of run off with it, which is what we're seeing a little bit of in the media right now. And then there's a lot of nurses who are saying that maybe their employer or their colleagues feel like this is just the flu again and it's not worth this level of response, the isolation and the school shutdowns and the restaurant shutdowns. The reason why everyone in public health is advocating for this extreme response is because it is more contagious than the flu, and they still aren't certain how much more contagious or why it's more contagious. So until those things are really figured out, we don't have a way of preventing that spread. We don't have a vaccine yet, unlike the flu, where we can mitigate the concern to some degree. And it's also got a much higher fatality rate. So the mortality rate is in between 2 and 3% depending on the studies. These studies are going to be a little skewed because as they're testing people, they're discovering more and more people who had the virus but didn't show any symptoms. So these people were kind of missed in the beginning when they were calculating the numbers. But 2 to 3% mortality is what we're looking at right now. The flu has an under 1% mortality rate, so a very, very low mortality rate in the majority of people. So that's why this is so concerning, because it's very contagious. We aren't exactly sure why it's contagious, and we know that it has a higher mortality rate than the flu. So those are some of the basic information that's coming out. We'll keep you guys updated as we hear more. especially as scientists develop the vaccines and hear more about its properties. And also, there was a question we had a lot about, are children affected? Are pregnant women affected? There have been very, very small studies done on maybe 4 to 6 women that were infected, and there were no ill effects found. But as I said, that's very limited. Hopefully that data will be coming out in the next couple of months. And then for children, it seems that children do get the virus, but they just don't show symptoms. So we're probably missing a lot of kids in that tracking, just like we're missing a lot of adults that don't have symptoms in that tracking. So as those numbers come out, we'll be sure to update you. So I am going to shoot it back to Serena. Belinda, do we have any questions that have come in? Belinda, do we have some questions?
We have questions. I'm sorry, I was talking and apparently muted. The question is, are hospitals changing or stiffening protocols regarding nursing students in the clinical setting or on certain units?
Can you hear me? This is Serena.
We
Yes,
can.
go ahead.
Okay, great. I just wanted to make sure I was clear. We do know that many of our nursing schools take students out of the clinical setting during this time and place them in a simulated environment to finish out the semester. We also know that some of our hospital facilities have expressed that, there's with so much going on, putting those students at risk in this, during this environment might not be in the best interest of the students either. So that's what we know at this time, and what the majority of our schools of nursing have moved to. Do you have anything that you want to add to that?
This is Cindy. I would add, I am hearing of facilities limiting students, including APRN students in non-hospital settings, but still healthcare settings, or requesting that students who are already licensed nurses take on like staff type roles. So a number of schools are having to look at their practices and what is appropriate in those situations. The Board of Nursing has been very responsive in looking at and reminding schools of the simulation requirements, as are the certification agencies, from what I'm seeing, that they are looking at and kind of relaxing some of the requirements so that students are able to complete their experiences. So I think generally we're seeing responsiveness of many groups trying to adapt and respond to these challenges. It's difficult for everyone, and I think especially for students who are trying to finish their education. So schools are being very creative in those experiences. Everyone is, I think, looking out for safety of patients as well as providers and our future providers.
All right, next question. I work at a large acute care hospital, level 1 trauma center in North Texas. Does TNA have information or suggestions on how sick or possibly exposed medical staff should be handled? Data is showing that 80% of cases are being spread by people before they become symptomatic. So if facilities are doing what my facility is doing, which is letting nurses work until they develop symptoms and then test, thus nurses could be spreading COVID-19 asymptomatically while being forced to come to work. Is there a suggestion for when a nurse does get sick and is confirmed positive? What else is going on around the country?
I will, this is Cindy, I'll gauge attempt a response to that. I have been asked that question, and I have looked, although I haven't had a lot of time to spend looking I have not seen guidelines, and Kanika and Serena, I don't know if you have seen guidelines to advise healthcare organizations about screening their staff, other than temperature checks and all, but that's a symptom. I have not seen recommendations if someone is suspected of carrying or of an infection, recommendations of removing that person other than what's recommended for the general public. So I think this is something that generally we look to like the CDC and some of these expert organizations to advise us. Thus far, I have not seen recommendations. Kanika and Serena, have either of you? You're muted, Kanika.
Thank you. I haven't seen recommendations yet either, but we'll definitely look for those and double check if we missed them. The other part of it is that, yes, you are contagious, for up to 14 days before you show symptoms. About 5 days is the average right now. And you're also contagious for several days after showing symptoms. So we might, your employer, your facility, as they're evaluating procedures, might want to look at also what other countries are doing, that they might be further down in their responses than we are. We're also hearing concerns about the availability of tests. And so hopefully once those tests get out to the different states, distributed properly, that we'll be able to test a little bit more. So if we know someone's been exposed, they'll be able to get tested before they start showing symptoms. But all of that is, it's going to be on the CDC's website as the information becomes available.
Next question. The scientific evidence indicates there are GI symptoms that also arise early, yet we're not hearing of screening for patients with these symptoms. Additionally, early or mild symptomatic patients are not coming to be tested. In fact, they are being told to stay home. The denominator is likely not accurate due to these issues.
Yes, that is
I guess
correct.
that's a statement.
Yeah, that is correct. We have not tested everyone with symptoms, so we are hearing from healthcare workers on the ground that there's potentially more people out there that haven't been tested. So we'll see that number get a little more accurate. The other thing to consider is the number that we see today is also, it's really a snapshot back in time. I was hearing someone on NPR speak about this, that in all the time that it takes to develop symptoms or even be exposed and then talk to a healthcare provider and then get the test and get the test results back, we're really seeing numbers that were the people that got infected about a week ago. So that's something to keep in mind too. So if we see the numbers jump up dramatically tomorrow, it's not really that so many more people were infected overnight. It's really just that people that may not have had symptoms, or people who weren't able to get tested because of a lack of availability of tests, or even just the lack of knowing who to go to for tests. Those cases, we'll see those cases pop up, and will become, those numbers will increase pretty quickly, I think. The other part of it was the GI symptoms. Yes, there are some minor GI symptoms, but they're not enough that they could distinguish between, coronavirus or influenza or colds, rhinoviruses. It's not enough to really be a distinguishing feature, whereas the dry cough, the respiratory shortness of breath, those are the real distinguishing features, and that fever too. But yes, there are some GI symptoms that are appearing.
I would like to add too that I think with a shortage of test kits that are available, they're being prioritized, which is part of the reason why people that may encounter minor symptoms are being advised just to self-isolate. We don't want those people showing up in the emergency department, because that contributes to that overwhelm of the system and isn't helpful. They can self-isolate and they can call their healthcare provider to determine next steps and the priority in the testing. When more tests are available, then that triaging of who gets tested will change.
I have another question, a follow-up to one of the other questions that wants to know if If you're caring for patients and not knowing if you have the disease because of no symptoms, is it best for nurses to wear masks at all time for all the patients, or is it a waste of supplies?
What I am hearing is that is not being recommended because it does use up supplies. I don't know, Kanika, have you heard other recommendations?
I think from an infectious disease standpoint, a mask might be advisable just to, if you know that you are symptomatic or that maybe you have the flu, maybe you have something else, or even just allergies, it's advisable. But again, yeah, that shortage is a real concern. I know that DSHS announced that they were able to request and they received some supplies from the federal stockpile. And so that might ease up on the shortages currently. And so I would just recommend that you stay in good contact with your employer about that, and just double check about your facility policies, as you would know how many supplies that you have. Some places are, of course, more well-stocked than other places.
All right, one more. If I take care of a positive patient and I'm exposed, should I put myself into a 14-day quarantine? And is my facility going to pay me for that time that I'm in quarantine?
Well, the paid time will be dependent on your facility policies. So that would be a question to raise with your employer. I don't know now that there is I know the federal government is trying to do a lot of things to support individuals that are at home, but I think many healthcare organizations already have policies in regards to that. So I think that would be the first place to go with that. In terms of exposure, I guess I wondered, does that mean just caring for someone, or does that mean knowingly that you have not protected yourself and this person is infected with COVID-19? And Kanika, I don't know if you have I don't know what the CDC is recommending in that case.
Yeah, I think it's a little up in the air. There's still questions of why the virus is so contagious. It lives in droplets. So, if you were not in the vicinity of the patient and to be able to inhale droplets, and if you followed proper PPE and hand washing and weren't touching your face, you're probably a much more less likely to contract the virus.
So the questions are coming in. Do y'all want to continue to take questions, or do you want to move on with content for a while?
Well,
I was going to say, next up is for you to talk a little bit about the facts, transmission, latest research, and that might actually answer some of the questions.
I was just going to say that, yeah, because I've actually got a list of a lot of questions here from nurses. So I'm going to try to go through these, and hopefully that'll cover some of the ones that are coming in also. So we already talked about the risk that it is more contagious than the flu, more contagious than colds right now. It is not as contagious as measles. I'm not sure if everyone watching remembers how contagious measles were at the height of it, but it's not as contagious as measles. It's not airborne the way that measles is. That measles can live in a room for up to 8 hours after someone's in the room. So that doesn't seem to be the case yet. So we're still, researchers are still looking into that. Some of the other questions are, how long does the virus remain on surfaces after being shed? There was that recent study, the same study that did the aerosolized droplets. They studied surfaces as well. They found that on some surfaces like stainless steel, it could last for up to 2 days. So that's why we really want to emphasize washing hands and wiping down surfaces. Something that we have recommended to people is, make your house kind of a safer zone. So if you're running out of cleaning supplies or you're worried, make it a habit. I know not a lot of nurses already do this, but when you walk into the house, make sure your outside clothes go separately, that you're changing, and that you're wiping down like your purse, your phone, things like that. So anything that could have come in contact with surfaces or with other people's hands, they're being wiped down as you enter the house, and that way you won't have to keep thinking about it all night long or keep keep wiping down the same counters. In workplaces, especially for those of you who work in offices, keeping those common areas clean, and in hospitals and facilities as well. But in offices, wiping down the keyboards, shared break rooms, any shared spaces like markers that are being reused. I went to the doctor yesterday, actually, and what they had done was they had every patient take their own temperature with the forehead thermometer, take their own blood pressure with a wrist cuff, and then they wiped down everything as it was handed back to them. So there's lots of procedures that you can put into place and that don't take a lot of extra time. This actually was really quick, and there wasn't a nurse that had to stand there and wait for me. So that was really efficient. Another question was, can reinfection occur? We are unsure. There was one study published about a woman who did seem to get the virus again after she had already recovered from the virus. But there's also a lot of evidence of people building immunity. So people having antibodies in their system, way after they've had the virus and that symptoms have subsided. So we're seeing a little bit of both right now. There was also a study that the virus had mutated a bit, and so that's always a potential possibility, like with influenza or with rhinoviruses, and some colds are also caused by coronaviruses. So we already know that cold viruses mutate quickly. So that's also something that scientists are watching out for. So the reinfection question is kind of an unknown right now, but it does seem like immunity is happening. Another question, I think I answered this before, the pregnant women, there's been a very, very small study on pregnant women and no effects were found to the fetus. The incubation period. So generally the incubation period has been about 1 to 14 days before symptoms. There was maybe 1 or 2 people that have had incubation periods that are longer than that, that were published as case studies. And 5 days seems to be the average. There's another issue though, is that a lot of younger people are not showing symptoms at all. And so if you look at the charts, and we'll link all of this for you, if you look at the charts of mortality, you'll see that it rises with the age group. And part of that is that the younger folks aren't showing symptoms, or if they do show symptoms, they are getting better. About 20% of cases are severe enough to need hospitalization. So that's really what we're concerned about, is that 20%. Imagine if everybody in America, 20% of us all went to the hospital at the same time. It wouldn't be possible to handle. So that is really the thing to emphasize, especially with patients. The patients that aren't really concerned, try to emphasize that part of it. If everyone gets sick at once, it's really going to overburden the system. Some other questions. What can clean or kill the virus off surfaces? Bleach solution is effective against the virus. Chlorine solutions are effective also. I am still looking into vinegar. I've heard some professionals recommend vinegar, but vinegar doesn't work against certain pathogens. So I'm going to double check that, and I will make sure that the accurate information is online in the FAQs for you. And then hand sanitizers. Hand sanitizers are effective against viruses. They will disrupt the membrane. So in general, they're effective against most viruses. So the CDC recommendations have been about, you need to have enough on your hands for them to be wet for 15 seconds, and you need to rub and have that friction. As you all know, you've got to have friction when you're hand washing too. So just remind people that hand sanitizer isn't just like I'm going to spray it on my hand and I'm done. They've really got to get their hand wet and rub it into their skin in order to get that effectiveness that the sanitizer bottle claims, 99% effective. To get that effectiveness, you really have to have it on the skin for 15 seconds and have that friction. But it is effective. And soap and water hand washing is really just the best way to stay safe. When are patients contagious? I think we already covered that one. Can you transmit the virus without having symptoms? Yes. So that is the big thing that is kind of scaring people, is asymptomatic people transmitting the virus. The other part of it is that even symptomatic people are transmitting the virus because they are ignoring quarantine requests or isolation. We've already heard of cases of one man had the virus and he went to a party that night instead of staying home. In South Korea, they traced 1,000 cases to a single person who decided to disobey that quarantine order. And so that's the scale that we're looking at, that one person could really affect thousands of people just by not staying home when they're sick. And so I think if you are faced with patients, there might be two sides. There might be the patients that don't believe it's happening and the patients that are really freaked out about it. For that other group, the ones that are really panicking about it, I think the best message would be that this is a virus. We know how to treat it. We know how to identify it. If you ever feel that symptoms are coming on, you can see a healthcare provider. The healthcare system is not going to shut down tomorrow. So just let them know that we're taking precautions now so that our system will still be in place in the future. And it's a good thing we're taking precautions. It's very scary to have schools closing and restaurants closing, and you walk down the street and it's like a ghost town outside. That is pretty terrifying for some patients. But all of that is in prevention. So to prevent it from getting worse, we're doing that now. And that is also what the UK study, the modeling study that I mentioned earlier. I know we have a couple of new people in the webinar today, or right now, I mean. That UK study, the modeling study, really looked at what happens if we put everything into place right now and we maintain it for several months, or what happens if we go through a period of maybe 2 months isolation, 1 month back to normal, 2 months isolation, 1 month back to normal. And so they looked at several different scenarios, and I know that a lot of the governments, including our own, are looking at this study to decide what to do moving forward. So yes, there's a lot of unknowns right now, but right now, shutting everything down is the safest thing that we can do before a lot of people get sick. I think that about covers the major questions that we had. Cindy, you think I missed anything? Serena?
I would just add that I know there are many of our physician offices in the state that have been working really hard to incorporate telehealth as a way to see patients and avoid having patients come into their offices. Governor Abbott just released some of the regulations around that to make it easier for these offices to incorporate telehealth into their work environment. And I know I was just at a visit with my daughter the other day, and they're already working on incorporating that. So when we go back next week, it's readily available and we don't have to leave the house. So it's happening in real time.
Okay, let me speak a little bit to what some of the other organizations are doing at the national level. ANA really quickly.
Excuse me. This is Belinda. I hate to butt in. We're getting lots of questions, and they're more related to what's happening in the facilities than maybe what we're talking about. So I'm wondering if we could take a couple more of those.
Sure.
And then come back to the other organizations. Okay. This one says, I'm working in a large teaching hospital. Several of my units fall into a high-risk population due to age and chronic health, such as diabetes, etc. Our unit has a low census, and they're requiring us now to float to much higher risk areas of the hospital. Is there any guidance on any protections available to those of us in this situation?
You know, I think practicing good PPE and hygiene when you're working in those other areas. And I also think that monitoring, you know, they're doing temperature checks and those kinds of things for, you know, healthcare workers, all healthcare workers, to try to identify any possible infection as soon as possible. I do know, especially if there's a unit that's down in census, I am hearing that there's a tremendous need for all hands on deck, so to speak. So I think that's a very valid and real concern. And I think it's kind of like, just like when you have a patient assignment and you may have one patient who's infectious and others who are not, you're going to do the best you can to practice that hygiene to ensure that you're not transmitting between patients.
All right. I'm facing issues where my nurses have travel plans to states that are already hot zone areas. They are aware of the 2-week quarantine upon return. It is causing staffing issues in our units. Are there any recommendations?
So if I understand this correctly, these are nurses who are going to travel to a hot spot, say New York, and then come back knowing that they'll have 2 more weeks of quarantine, which means they won't be able to work. I think, you know, that is something that individual organizational policies, if someone they're knowingly going to be away and cause an additional 2-week absence, and I don't know what the employer's policies may be about that. I think all of us, this is a time, there was one article I read, and it wasn't really an article, but I guess it kind of was more of a blog, but it really said the time right now is when it's not about me. It's not about us. It's about the folks that are vulnerable. And so we all need to make sacrifices to protect the greater good. And as nurses, that is really something we're called to in terms of social justice. That I had a vacation planned to a zone that's not quite a hot zone, but it's close to a hot zone. And I need this vacation so badly because I have not had, other than a staycation, in well over a year, just because of things in my personal life that have required my time off from work to be caring for family members and other obligations. I am canceling my vacation, not because I feel at risk or believe that I'm at risk of getting ill and harming myself, but because I know that by traveling, even to an area that isn't a hot spot, that I could become a carrier. I am participating in an activity that may jeopardize the overall country's response to this pandemic. And again, this is my opinion, but it is what is being recommended from everybody that is making recommendations about containing this pandemic. And it is about, we all are required to make sacrifices in our own behavior for the good of all. Because what is threatened is an overwhelm of our hospital system. And what Italy is facing now is about making ethical decisions about who gets care and who doesn't, because they don't have the bandwidth to care for everybody. And they have more hospital beds than we do, and we have a greater population than they do. So I think that every one of us needs to really carefully think. Nobody can make that decision for you, but we need to carefully think about that. I think it's a great conversation for employers to have with their employees, and about it, you know, I think that the greater issue, rather than just that nurse being out of the workforce, is what are we as healthcare professionals who are informed and should have evidence-based practices, how are we reflecting that in the decisions that we make? And I'm sorry, that may sound like a soapbox, but I think we need to take this seriously. Hanukkah just said 18 months. I heard that today, and I about fell off my chair. This is serious, and we need to have these conversations with each other about the impact, because I'm not sure everybody realizes potential impact.
And Cindy, I would just follow up on that. I was talking with an infectious disease physician within the last week, and when he said this, it was really an aha moment for me that this virus is really all about, in preventing the virus, is all about human behaviors.
Right.
And human behavior includes making those conscious decisions to travel to a hot spot. The human behavior is, do I wash my hands for the full 20 seconds? Am I going to ensure that, you know, I'm a little more diligent in making sure that things are clean, including my phone and the other surfaces that I may touch? You know, I went to the gas station to get gas, and I thought, oh, I don't even want to touch this, but I made sure to put my hand sanitizer on after I, put the pump back and got in my car. But it's being very intentional in changing our behaviors. And, I think a great example of that is 9/11. Before 9/11, we got to come and go as we pleased inside the airport, and we didn't have all the regulations and all of the strict rules that we had to follow. But we very quickly adapted after that, and now we make sure we get to the airport 2 hours ahead of time, and we're used to all of the things that we have to prepare to do before we walk through the checkpoints. And we complained about them in the beginning, but now they're just part of our daily travel routine, and we have to start changing our routine now in order to prevent this disease, or this virus, from spreading any further.
Next question. Are there any home health care precautions and recommendations? I've called the CDC for more information, but the majority was for hospitals and long-term care facilities. Due to the fact that the majority of our patients are geriatric, what extra precautions should we be taking to keep them safe in their own home?
Who wants to answer that?
I would say, Kanika, go ahead, and then I'll follow up behind you.
Just from the public health standpoint, I'm not sure about the nursing practice standpoint, but there are a couple of suggestions that are out there, especially for nurses to wear PPE, make sure that those home health clients are isolated, that other people aren't really coming and going, so that would reduce their risk also. And then that they're able to, get their meals delivered in a sanitary way. Those kind of small things that we take for granted in that setting. So that's really what the recommendations are now. But as you said, the CDC recommendations are really for those larger facilities, and there hasn't been much for home health. So Serena?
I was going to say I agree. There have not been, a lot for home health. What I would recommend is talking with your leadership within your home health organization to come up with some of those potential solutions. For example, prior to going to the patient's home, do you screen them for some of the signs and symptoms of COVID-19, or anyone else in the home for that matter, to see if maybe there's been exposure, so you are a little more prepared before walking in? And what is the protocol for PPE when you're caring for patients who do have a potential virus such as COVID-19, and how do you protect yourself?
I would like to take just a couple minutes, because some of the questions that we've gotten, something that has impressed me is that when I've talked with frontline nurses, I hear about that there's a lack of communication, they get conflicting messages, that policies and procedures and protocols are changing day to day, what they're supposed to do, and there's confusion. There's concern about the adequacy of PPE. That's a paramount concern. And then I hear from leaders about all the things that they're doing to put in place. And it seems like there's a lack of consistent, clear communication between the two, between those on the front line and those that are in leadership positions. So I think if there's a takeaway, that was my main takeaway, is that right now we cannot over communicate. I think it is important for frontline nurses to know that the Hospital Association is making a number of efforts. They're very connected on the national level. They've had conversations with the governor, and the governor with the federal agencies about accessing stockpiles. They've activated the regional advisory regional advisory coalitions, I guess, who manage the trauma services to kind of coordinate supplies in those different regions. So there are a number of things that are in place that we would expect from a disaster preparedness standpoint for organizations to be mobilizing. Much of that is behind the scenes, and sometimes frontline nurses aren't aware and don't feel the impact, because some of that takes some time to get ramped up. So I do feel that the need to let folks know that there are those things happening behind the scenes. There is hospitals as a whole. Now, I can't speak to individual, I'm sure there are outliers, but as a whole, I know the Hospital Association is taking this with a lot of seriousness. They have a lot of information on their website. The American Nurses Association had their website up very, very quickly, and they continue to update it with information relevant to nurses. And on the national level, they had a conference with Vice President Pence today, speaking about some of the issues and some of the concerns. So there's things happening on the national front there in terms of the national group advocating. And then the Medical Association also. You may be aware that there was a letter sent, I don't know if it was last week or earlier this week, by the three groups, the Hospital, Medical, and Nursing Association, asking for a quick national response. So there's a lot going on by organizations on the larger front that frontline workers you may not feel the impact of yet, and you might not realize is going on, but we are working behind the scenes to support you. And I think that's important to know. If there are nurse leaders on the call, I can't emphasize the enough of ongoing, constant, clear communication throughout the organization, so that you hear from the front line what the issues are, and so that you are communicating what you are doing about them. I think that also instills greater confidence and trust. And that is what we need right now. Fear is not a good place to come from when you're responding to something. And I think we're at our time. So I don't know if there's any final comments, Kanika or Serena? You're muted, Kanika.
Sorry, I'm muting myself to type. Belinda, could you let us know how many other questions there are? Maybe we could do one or two final questions.
I probably have about five more questions that are here right now. Do you want me to go through them, or do you want to?
Well, if you could just choose one or two, and then we'll answer the rest of them online. Yeah.
Okay. So one of them says that you've talked about PPE on the CDC website under the interim infection prevention and control recommendations. With suspected COVID-19, it mentions their guidance is not intended for non-healthcare settings. Specifically not mentioned are schools. Even though schools are closing, there are some that are still open, and there's concern for school nurses being excluded from the PPE. Do you have a recommendation for the school nurse in the use of PPEs?
I think let's look into that because I'm sure that there's other settings as well. And we will try to provide some guidance on that, or at least find, what other places are doing that is working for them. But I don't think we could say off the top of our heads right now.
So another one is, what about competency? If nurses are being pushed to cover higher level of care units, what are the protections for them?
So I don't know if this refers to like a nurse being floated to a higher level of care. The nurse should be oriented to that higher level of care, and or assignments should be modified so that the nurse is practicing within their scope of competency. Otherwise, the nurse does have access to a safe harbor, to evoking safe harbor and having that assignment reviewed.
Again,
also, this is just a point of.
If you joined us late, the safe harbor information is on our website too.
This is a point of information. The National Association of Home Care and Hospice can assist nurses in visiting information related to the COVID, and it is on their website at the nahc.org.
Great. Thank you so much for that.
And then there's one more here. Did they lift restrictions on nursing licenses so that people can go across state lines to practice for areas that are in an emergency?
Yes. That has been waived by our governor. And the board of nursing has been extremely responsive and very fast turnaround, looking at requests of being flexible, not only with nursing education, but with other licensing requirements. For example, if a nurse is due to relicense and they haven't been able to meet all their C&E, and they were depending on all these conferences that are being canceled right now to attain that C&E, the board will take that in consideration if the nurse comes under review for C&E and does not have the amount. So we are seeing a great support across the board from organizations recognizing the seriousness of this emergency and the impact it has on the community.
All right. I think that covers most of the topics. There are more questions here. We will download all of these questions and take a look at them and see if there are things that we need to add to our FAQs on the website. We do appreciate everyone's time. We hope that we've provided good information. If there are things that you think we missed, please send those to us at tna@texasnurses.org. And we will be doing another town hall type meeting tomorrow at noon. So if you want to join us again to see if you can get your questions answered, that would be great. So everybody have a great evening. And again, thank you very much for attending.
Good night.
Good night.
Right.